Hello student. Today we are going to deal with a very fascinating topic. It's about the heart disease. Heart, how in utero, during its evolution from a single cylindrical structure, how it becomes four-chambered heart, and when changing, what are the congenital anomalies they can have. Yesteryears, when it was said that the baby is having a blue baby or a bluish discoloration, it was almost certain death, whether it's in a newborn period, infancy, or in early childhood. But the things have changed. The surgical skills have opened, technology has improved, then the diagnostic modalities have improved tremendously. Now, many of the diseases can be completely cured, and these babies can become as normal as possible with total correction. I want to just share a small story of one of my patients. When I was a postgraduate, this baby used to come with a cyanotic spell. He had a disease called tetralogy of Fallot. They were from a very poor family. They couldn't afford surgery, even a palliative correction could not be done. He was getting recurrent cyanotic spells, and he continued his journey as a school-going child, from the preschool childhood to the adolescence. Again, when I came back to India, I met him in a medical college where I was working. He was 16 to 17-year-old child. Somehow, he was given an appointment with one philanthropist who said that he will help him with the money for his total correction of this disease. Poor guy. He was getting recurrent cyanotic spells. He used to get admitted recurrently. He had actually cerebral abscess once with seizures. He was becoming sick and sicker as the days goes by. Then the father decided to take this offer and go to Mumbai, where the surgery was supposed to take place. They boarded the train from Mangaluru to Mumbai. On the way, somewhere near Ratnagiri, this child, or adolescent I would say, at 17 years, had a severe cyanotic spell, and he died there in the train. You can imagine what is the sorrow of the father or the mother. Everything was sort of a set for his surgery, and yet so near, yet so far it was. Almost he was near to the surgical correction, but fate happens to be and looked the other way for his total correction. That child died, and they couldn't do the surgery, and the parents were crestfallen. With this, I would begin this topic of congenital cyanotic heart disease. You know that congenital acyanotic heart disease, many malformation occurs. Similar way, cyanotic heart disease also, there are many diseases. Today's learning objectives are approach to cyanotic heart disease. They can present with the different ways, but how do you approach cyanotic heart disease and clinically diagnose and manage this child? Diagnosis of different cyanotic heart diseases. What are the investigation we can do? I'll take you through various clinical scenarios, each one presenting in a different way, and how do you manage this child, broad basis. Let's start with this first case. That this was a 3-year-old boy brought to a hospital with complaints of bluish discoloration around lips, which the mother noticed initially at the age of 4 months when the baby was crying hard and straining. So we should know what is cyanosis. Cyanosis is deoxygenation of hemoglobin. Cyanosis is bluish or purplish tinge to the skin and mucous membrane. It requires approximately 5 grams per deciliter of unoxygenated hemoglobin in the capillary. That means to say that a baby who's having 4 hemoglobin, baby who's having hemoglobin of 4 may not manifest with cyanosis because it's the deoxygenated, at least 4 to 5 grams of hemoglobin deoxygenated hemoglobin should be there to manifest with cyanosis. Cyanosis is recognized at much higher level if the child has got polycythemia and at a lower level of oxygen saturation in a patient who has got anemia. There are different types of cyanosis. One is central cyanosis, which the cyanotic heart disease presents with. Second is peripheral cyanosis. That means only in the periphery it will be cyanosed, especially when a person is exposed to cold, chilly weather. What happens is peripheral vasoconstriction occurs. He becomes hypothermic and you can have peripheral cyanosis. Also, in a child who has got congestive heart failure, what happens is because there is increased systemic venous resistance because of the peripheral vasoconstriction in CCF, they can get peripheral cyanosis. Then you can have mixed, both central as well as peripheral cyanosis, which occurs in congenital heart disease with the congestive heart failure. Then you can get a child who's having a differential cyanosis. That means the upper limbs will be pink and lower limbs will be cyanosis. This occurs when a child who has got a PDA with shunt reversal. That means what happens is the baby has got a persistent ductus arteriosus. That means there is a flow from the aorta to the pulmonary artery. Now, if happens in such that, because if you see, it's always left to right shunt which is occurring in PDA. Now, because of Eisenmenger or over the time, the pulmonary vascular resistance increases, right-sided pressure increases more than the left-sided pressure. Now what happens is, from the pulmonary artery, the blood goes to aorta. That means here the pressures are more, right-sided. So there is deoxygenated blood goes to the aorta and gives rise to cyanosis, differential, because what happens is this, the attachment is at below the subclavian. So what happens is the blood which is supplying, the blood vessels which is supplying blood to the lower limb will get deoxygenated blood. That's the reason why they get cyanosis. That's why lower limb will be cyanosed and upper limb may not be cyanosed. Also there is what is called as a reverse cyanosis, that is reverse differential cyanosis. That is in a child who is having a TGA with PDA with a shunt reversal. Just the other side. So you have a upper limb cyanosis and lower limb pink which occurs in a TGA. That is because transposition great arteries, because pulmonary trunk behaves like aorta and aorta behaves like pulmonary artery. So that's why it is a differential cyanosis in a reverse way. Then you get intermittent cyanosis in a condition called Epstein anomaly, which we going to discuss later. There you get intermittent cyanosis. Whenever there is a large amount of deoxygenated blood going into the circulation, you get cyanosis. When it's equal or a well mixed blood, then you may not get cyanosis. Sometimes you get cyclical cyanosis. This is basically a structural problem, what is called as a choanal atresia, because if you say the nasal bone gets fused or it doesn't open up in a developmental process. Babies are obligatory nasal breathers. So whenever babies involuntary cry only, they can breathe if the nose is blocked. So when they cry, they become pink. When they don't cry, they become cyanosed. This is called a cyclical cyanosis, which we see in choanal atresia. Now, how do we identify cyanosis? That is, whether it's a true cyanosis or it is cyanosis-like episodes or diseases. That is, usually true cyanosis is associated with clubbing, and also ABG will definitely show a severe hypoxia which can be detected in it. Whereas in cyanosis-like, it is not associated with clubbing. For example, you have Meth hemoglobinemia and Sulfimoglobinia. These are the two conditions which needs to be confirmed. So Meth hemoglobinemia, what happens is that the ferrous part of the hemoglobin gets converted to ferric form. So these people present with, or the patients present with severe headache, breathlessness, cyanosis, all these conditions. Then sometimes sulfimoglobinemia. This is because patients or children who was exposed to some of the drugs, usually large amount of furosemide. So these, what happens is there is a conversion of sulfimoglobinemia. Here they also have this tinge of cyanosis which is in them. Then there is what is called as a pseudocyanosis. This is because of bluish tinge to the skin or mucous member. That is not because of a deoxygenated hemoglobin. It is because of the metals, heavy metals or some drugs which are causing that. These are especially when the child is exposed to heavy metals like silver or lead or some drugs like phenothiazine, amidron or chloroquine for a long time. They get that bluish tinge in the mucous membrane and in the skin. So let's come back to this case. The bluish discoloration was noticed only when the child was crying hard. Now he has become increasingly getting this cyanosis. He is often seen squatting during or after the play. He plays for some time, then he squats like this. Now, he had a normal birth history. No such episode in the neonatal period. Mother noticed the cyanotic spells were not there. On examination, there was cyanosis, there was conjunctival congestion. What happens is they get into polycythemia. So the conjunctival congestion will be there. Then grade 2 clubbing was there. Heart rate was 100. Respiratory rate was 35. SpO2, that is pulse oximeter reading, was 75 in room air. His cardiovascular system showed parasternal heave. There was parasternal heave and grade 4 to 6 ejection systolic murmur in the pulmonary area. ECG we saw, it was right ventricular hypertrophy was there, and a chest x-ray is here. You can see this chest x-ray. Anything? You can see this child who has got a chest x-ray here. What has happened is there is increasing right ventricular hypertrophy because the apex is lifted up. Here you can see the pulmonary bay is empty and there is a little concavity here. So let's find out what it is. So does this child have a congenital cyanotic heart? Yes, this child has got congenital cyanotic heart.